So good evening, everybody. Thank you for joining us on a Saturday evening for this very important PG masterclass. The class is going to be moderated by none other than Dr. V. Ravi, who actually doesn't need an introduction on our platform with his long list of accomplishments and our past presidents of IMM. So we have four speakers today: Dr. Himanshu Chauhan from NCDC, Dr. Anupam Prakash, Director, Professor, and Head from Medicine, Lady Harding Medical College, Dr. Madhumita Barua from NCDC New Delhi. Now, Dr. Nivedita Gupta will not be able to join us today because there is a very important meeting and mock drill going on Ebola virus preparation, which has been scheduled for today. But she shared her presentation, and I will request Ravi sir to please do the honors by taking her presentation. And over to you, sir, to begin this.
Thank you, Dr. Sonal. Good evening, everyone. Distinguished speakers, PG students, colleagues, and friends. It's a privilege to moderate this IAM masterclass being conducted by the Indian College of Medical Microbiologists. I think viral hemorrhagic fevers are not new, but the way they are presenting to us is new. The disease is more than 4 decades old, 5 decades old almost. Uh, the way they are presenting in new geographies, the new ecological drivers, new travel related risks, new diagnostic expectations. I think these are the things that we will be discussing today. We have a very distinguished panel, as Dr. Sonal has introduced. We must keep in mind that whenever we talk of the current Ebola that has emerged in Central Africa and Congo and Uganda, that Marburg is also another disease, although so far we have not had a global scare of it, and other viral hemorrhagic fevers, our own dengue and leptospira and others. For India, the message is very clear. It's not to panic, but preparedness is the key. And the way we isolate and we follow infection control protocols and quickly identify risks in patients who are arriving in India, these are the most important, and especially the precautions one should take while handling specimens or these patients. We have a well-prepared laboratory capacity, and I'm sure we will be able to handle as and when we get a case. So with these few words of introduction, let me request Dr. Himanshu. Dr. Himanshu, to give us the global, epidemiology and the landscape of viral hemorrhagic fevers. And then we'll have Dr. Anupam Prakash talking on the clinical aspects. Dr. Himanshu, please. I saw he appeared briefly on the screen.
Dr. Himanshu, are you there? I think
Maybe
I
he's
also.
on.
No, he was there. I made him the co-host. If you are not able to share, then I'll share the PPT. If you share it with me. We have a full house, sir. 100 participants. If any of your friends can't join, please ask them to join via the YouTube stream.
If Dr. Himanshu is busy, then Sonal, I suggest we ask Dr. Anupam Prakash to give us his presentation on clinical spectrum.
I think we can begin with Dr. Anupam. Meanwhile, I'll
Yeah,
call Dr. Himanshu and ask.
yeah, Please go ahead. Thanks. Dr. Anupam,
Yes, thank you, sir. I just a second, and I hope my slides are visible.
they're coming up.
Yes.
Yes, now they're visible.
So, thank you to Dr. Ravi, Dr. Sonal Saxena, and a whole lot of IAMM and ICMM for having me here. So, the topic that, as Dr. Ravi has already said, the topic that we are going to discuss is about viral hemorrhagic fevers, which are not a new entity, but yes, day in and day out, we do have routine cases, and at times, like Dr. Ravi said, scares also, and outbreak potentials also, not only scares, real threats also, which luckily, fortunately, and with hard work of each one of you and each one of the teams that we have, they have been contained till now. We had one pandemic already, which was not a viral hemorrhagic fever, but most of the viral hemorrhagic fevers have been limited in extent in India. So that is important. With that background, I will just move ahead. So the task is very clear. Dr. Himanshu, shall I continue? I see you.
Yes, yes, please, sir. Do
Okay.
continue, then I'll come after you.
Okay, thank you. So, the task for me is to highlight the early clinical features, identify hemorrhagic manifestations, and differentiate from common tropical illnesses, because we being a tropical country, we have these illnesses very commonly: typhoid, malaria, scrub, and a whole lot of other illnesses, region wise also, like leptospirosis, scrub typhus, all those things. And a couple of cases, brief cases only, and just to have a varied approach based thing so that we understand how to go about it. So this is primarily which I know Dr. Himanshu will be dealing more, but I wanted to discuss this or a minute because these are four primary families which all of you are well aware of, and the modes are different for transmission of each family. And importantly, as Dr. Ravi was talking, Ebola and Marburg, they belong to the same class. And we talk very often of Ebola. There are outbreaks. Marburgs, we don't hear so much. But they are primarily localized in Africa, as Sir said, Uganda or DRC, Democratic Republic of Congo, and the across border to Uganda. So that is the area from which it emanates. And there are a couple of patients which were under surveillance, which I know Dr. Himanshu will deal about in India. And the next is Arena viridi, which is basically localized areas. So it is Bolivian, Argentine, hemorrhagic fever, Lassa fever. So these are very localized areas. Now, the flaviviridi is what we are well versed with, dengue. But I will just highlight dengue is probably the safest of these illnesses. We are worried about dengue every year, every 4 5 years we have a peak. But if you calculate the mortality of dengue is less than 1%, which is not the scenario with others. The others are much more threatening, life threatening also, and the mortality is anywhere from 30 to 40 to 50%, as high as 40 to 50% in some of the cases. So, flaviviridi is probably the safest, especially dengue. And Zika also. KFD is localized in our scenario in Karnataka and the border areas that are of Karnataka. And we do have that viral encephalitis. It is just like Japanese encephalitis in areas close to Nepal border and Bihar. So this is important because Zika is also there. Dengue is rampant across India, a disease of urbanization that we say. Yellow fever, luckily, we do have a safeguard. We have an effective vaccine also. But it has a, if you have it, you have a higher mortality. So apart from that, we have this less commonly, but this was also, we all now people are vacationing, and you have those cruises also, and you had this hantavirus outbreak also on the cruise. So just like that, Crimean Congo hemorrhagic fever and Rift Valley fever, and these are not alien to India. Hantavirus may not have occurred in India, but Crimean Congo hemorrhagic fever, we had a case 6 7 8 9 years back in Rajasthan and adjoining areas. So we are being or facing viral hemorrhagic fevers day in and day out. And the threats are real. They are not just scares. They are real life scenarios, and it is important for us to recognize them. So I will try to cover these briefly. So why there is a problem is number one, platelet dysfunction, which we are very well versed with dengue. It is not only a quantitative dysfunction, so you have thrombocytopenia, but there is an element of qualitative dysfunction also. So the other thing is endothelial dysfunction, which is very important, which actually results in capillary leaks in dengue. So I will take the scenario of dengue to explain the pathogenesis and some other features and highlight the other illnesses one by one. So this is what is important. It is in dengue, the deaths are because of increased capillary permeability, which is because of an endothelial leaks. Then this is another problem. Many of the patients or some of the patients will develop coagulopathy and go into DIC, which may be the terminal event, but it is important. If the viremia is not controlled and the immune complex mediation goes further downhill, so you have coagulopathy and the patients will succumb to DIC. We also have multi-organ involvement. Once one organ fails, the kidneys fail, or there are capillary leaks, the intravascular volume is low, the intravascular volume is depleted, then definitely you have organ failure one by one. It could be the kidneys which fail first, it could be with the DIC, you have the liver, you have the brain, you have the lungs. So multi-organ involvement. And at times, it is not necessarily it is the intravascular volume depletion and widespread antibody antigen reaction. It could be a cytokine storm also. So these are by and large pathogenesis. Which patient will go which way? Or which patient may not have any symptom and will go unscathed or will heal spontaneously. So that is not right now known, and that is the problem. That is why any illness, if you have a symptom, especially during dengue season or in any other outbreak, you do feel threatened. The patients feel threatened. So this is just to summarize the pathogenesis and the spectrum. I said it could be mild, it could be asymptomatic, or it could be fever, myalgia, moderate. Yes, you have gastrointestinal or liver involvement, and severe. Obviously, we understand hemorrhage, shock, multi-organ dysfunction, DIC, cytokine storm, all those things. So, what pointers are there to early recognize these viral hemorrhagic fevers? Now, obviously, you have a febrile illness, but yes, there is a caveat. At times, the patient may not mount a febrile response, and patient may develop, or the febrile response may be a very brief episode which the patient may not appreciate, and the patient lands into other complaints, maybe body aches and other symptoms. But some things are important because this is not about now dengue. It is about viral hemorrhagic fever, how to recognize. So one thing is very, very important. Always ask history of exposure and which includes history of travel. So travel abroad, travel to an area, maybe Karnataka for Castor forest disease, encephalitis, or maybe Japanese encephalitis. Also, Japanese encephalitis is not a viral hemorrhagic fever, but still you have to ask for travel history because some of the diseases are peculiar in different areas. And even if there is a reason, if the patient is coming from a high from a city which has a very high air travel, like Kochi, like uh, there Delhi or maybe Calcutta. So all these things, or maybe where a lot of people are traveling, like Hyderabad and Kochi. These are two centers which are very often people are traveling to Middle East or African countries for employment and other travels. So you have to have that travel history, which is very very important. And at times you will the patient may be a secondary exposure, so somebody in the family has returned back from Middle East and now the patient has come to you because that patient was exposed to that contact. The other thing, obviously, for viral hemorrhagic fevers, one thing is thrombocytopenia. But again, I will emphasize thrombocytopenia may not be a very big problem because thrombocytopenia, yes, you have a solution. And most of these viral hemorrhagic fever syndromes patient, they do not die because of thrombocytopenia leading to bleeding. But importantly, thrombocytopenia is important to recognize these viral hemorrhagic fevers, number one. And number two, thrombocytopenia indicates the severity of illness. So these are two factors why actually you need to recognize thrombocytopenia. Not because of the sequelae which it will result in, because bleeds because of thrombocytopenia are much less in viral hemorrhagic fevers. They are mostly because of endothelial dysfunction or activation of platelets. It is not because of thrombocytopenia. So this is important. But yes, it will, I reiterate, it is thrombocytopenia tells you that it may be a viral hemorrhagic fever, number one, and number two, it will indicate to you the severity. In fact, if you go further down, convalescence also, once your thrombocytes start improving, you understand that yes, your patient will be recovering very fast. So these are factors which are important for recognition of viral hemorrhagic fever. Elevated transaminases, yes, like yellow fever, like Crimean Congo hemorrhagic fever, a lot of diseases, these viral fevers will affect the liver. Maybe viremia, but yes, it is important to realize that if the transaminases are elevated, it is a serious infection. So dengue hepatitis or dengue encephalitis. So if the encephalitis is there, then obviously it is serious. But if dengue hepatitis is there, then you have to be careful because this patient can go down very fast. Yellow fever again, it may be an ordinary fever, but if the liver is involved, that patient within 24 hours can go downhill into a fulminant hepatic failure. So that is the gravity of having a elevated transaminases. So red flags, yes, thrombocytopenia is one, elevated transaminases is other, and bleeding, yes, if you have any bleeding, I will come to that slide next. Capillary leaks or shock, these are red flags, and then you need to take care of these patients very rapidly. So once you have hemorrhagic manifestations, so petechiae, purpura, epistaxis, GI bleeding, pulmonary hemorrhage, and they have been enlisted in order of severity. So petechial rash may not be so botherable, but yes, it is a sign of severity. But if you develop purpura, so the bleedings are more, then definitely it may be a sign of DIC also. Epistaxis, yes, that is fluid bleeding. You need to take care of the patient. GI bleed may be occult at times. It may just manifest with hypotension or tachycardia, which you need to take care of. And pulmonary hemorrhages, mind you, if you have pulmonary hemorrhage with fever, fever with pulmonary hemorrhage, the mortality would rise to 35 to 40 to 45% or 50%. Most of the viral syndromes which have pulmonary hemorrhage as a manifestation, be it Crimean Congo hemorrhagic fever, be it the hantavirus pulmonary syndrome, these are diseases which will have a very high mortality. So that is the gravity. So that is why I have started, I have enlisted them in order of priority from clinical point of view. There is no yardstick. Nobody says that yes, bleeding is bleeding and you need to take care of. But the thing is, the mortality rates may be indicated by what severity you are having. So we talked of the capillary leak syndrome. So think of hypotension. If you have hypotension, very important. And before hypotension, it is important. Before the patient goes into shock or poor capillary refill, it is important that the pulse pressure becomes low. So there is a systolic blood pressure which goes down and the diastolic which rises up, which is the uh, condition of pre-shock. So hypotension along with a low pulse pressure, you should understand that this patient will go into shock very soon. So you need to give fluids very vigorously. And similarly, if you have hypotension, always check for hemoconcentration, especially for viral hemorrhagic fevers. Pleural effusion, yes. So these are all capillary leak syndromes, ascites, hypolimnia. These are all part and parcel. Hypolimnia is not part and parcel of capillary leaks, but it will indicate that yes, capillary leaks would be more severe. And even in a short illness of 4 or 5 days, if you have hypolimnia, it only indicates the severity of disease and in fact indirect involvement of the liver also. So when you have differential, so coming to the next part, so what all do you think of when you're talking of viral hemorrhagic fevers? Yes, dengue is very common in our country. The other infections which Dr. Ravi talked about, which we are worried about, which are not endemic to our country, are also important. But there are other tropical infections which come in day in and day out. So malaria, typhoid, sepsis, leptospirosis, rickettsial. I have not mentioned typhoid here, specifically enteric fever here, not because enteric fever has a different profile and usually it may be treated as an acute undifferentiated febrile illness. But usually the pattern of fever and the hemorrhagic manifestations are not there. So pattern of fever will be very characteristic and the hemorrhagic manifestations are not there and it will actually go beyond that limit of viral hemorrhagic fevers of 1 to 5 days or 7 days. So dengue is important. So dengue we by and large know. I have discussed also. I will discuss in the next slide also. Leptospirosis very important. Rickettsial infections, malaria, yes, very difficult to diagnose at times, especially if you don't have a good peripheral smear. So this is important. Sepsis, yes. So one by one, I will briefly say, if you have dengue and other viral hemorrhagic fevers, the most important thing probably when you are dealing with it is that severe bleeding in dengue is usually not common. It occurs very late in the disease. And you have more of hemoconcentration, more of serous effusions, ascites, pleural effusions than bleeding per se. And even with a great degree of thrombocytopenia, you will not have bleeding in dengue. On the contrary, viral hemorrhagic fevers like Crimean Congo or maybe Ebola or any other disease, you have viral hemorrhagic fevers, even if you have yellow fever in Africa. So you have a whole very severe bleeding manifestations. Exposure history is important. So dengue usually you don't have, you have the season, you have the endemic area, unlike for viral hemorrhagic fever where you will have a history of exposure. And both may show capillary leak, so that is not a differentiating factor. But yes, viral hemorrhagic fevers apart from bleeding may also show capillary leak because of endothelial dysfunction. When you talk of leptospirosis, yes, there are some very specific clinical signs. Conjunctival suffusion, jaundice may be there, and a biphasic illness. So maybe the second week or the after seventh day you have multi-organ involvement. And importantly, acute kidney injury is important in leptospirosis. So that is what is specifically called the Wales disease. And leptospira icterohemorrhage, as you say. So icterus, hemorrhages, conjunctival suffusion, and kidney injury. So that is a complex which is there, which is not characteristically seen with viral hemorrhagic fevers. So you have hemorrhages, but yes, transaminitis may be there, not necessarily jaundice. So that is important, and kidney injury is usually not there. So you have hantavirus renal syndrome where you will have renal manifestations and with mild transaminitis, but you will not have jaundice. So it is a totally different syndrome. So leptospirosis, by and large, you will have a clinical suspicion if you are dealing with those cases. Now, thinking of rickettsial infections, yes, it may be tough because there is multi-organ involvement in rickettsial infections like scrub typhus. But yes, if you have an SR which can be found in up to one third of the patients clinically, if you see, look for it in the covered areas, then it will give you a clue. But otherwise, it may be difficult to diagnose and different to differentiate. But again, rickettsial infections evolve over time. Maybe fourth, fifth day, you will have that severity. And viral hemorrhagic fevers will start with bleeding very early in the disease, maybe on the third or fourth day also. Sepsis, yes. But again, sepsis has a pattern and it will have a sequential organ involvement or you will have multi organ involvement, which will also be specific organs which are involved kidney, lungs. These are important. And bleeding is not common. So, sepsis progressing gradually into multi organ dysfunction and DIC. That is what is the usual scenario. You can have thrombocytopenia in sepsis, but leukocytosis is usually the norm, although you can have leukopenia at times. But viral illnesses will have prominent hemorrhage and invariably leukopenia and no leukocytosis. So, just syndromic approach. So, you have fever, you have thrombocytopenia, you have bleeding. So assess at times before you have bleeding, you should say, see for assessment of bleeding, ask specifically, especially bleeding through the GIT. And even if the patient is not aware, at times the patient may just be saying, I am having restlessness, ghabrahat or fatigue. You should check for pulse and blood pressure, which is very important because tachycardia and hypotension can give you clues that the patient is having internal bleeding and which can lead to shock. So always assess for shock and bleeding. So shock you can assess with the capillary refill time, which indicates that yes, the tissue perfusion is going poorer now. And as I said, assess for a pulse pressure, narrow pulse pressure in the pre-shock stage. You can pick up those patients. Evaluate exposure history and targeted testing, which is supposed to be the next talk after Dr. Himanshu. A couple of cases before I end my talk. So this is a 32-year male, 5-day history of high-grade fever, severe headache, generalized body aches, and profound fatigue. They're very common. This is usually with dengue also, but so any viral infection can present to you like this. So over the last 48 hours, he has developed nausea and repeated vomiting, profuse watery diarrhea, diffuse abdominal pain, non-productive cough, a sore throat. So this again could be part and parcel of viremia. So this could be, I don't have an option of mm, the questions. Is there any what is the opinion of the house on this case? If I can have a couple of comments. Anyhow, I will not take time. I will just say, see, 5 day history. Now, this is important. Most of you have over the last 48 hours, this patient has developed nausea, vomiting, diarrhea, non-productive cough, sore throat. Now, this is important. This is where the importance of history is in all these cases. Number one, this patient on by the fifth day, most of the viral illnesses, 5 to 7 day patients should viral illnesses usually start resolving. In fact, they resolve. Flu also usually resolves by fifth to seventh day, unless until some cases it may be 2 weeks, up to 2 weeks. But the problem here is that this patient has 5 day history and he has worsened in the last 48 hours. So that means this disease is worsening, which is a red I would say red alert for any clinician. So this is important. If you are not having a recovery by fifth day and the symptoms are adding upon, then you have to be very, very careful. So this patient had vague pains, and if you are suspecting dengue, always ask for retroorbital pain because that may give you a clue. Although it is not a specific sign, but yes, you may have a clue. But this patient again, dengue will not keep on worsening by the fifth day. So it is ideally supposed to start improving. But this patient has developed new symptoms in the last 48 hours. So next, this patient, when it was on the day of admission, this patient developed bleeding. So obviously we are talking of viral hemorrhagic fevers. So this patient developed bruises. Now I again said petechiae and purpura are different. Bruises are still larger spots. So that is the thing that is problematic with this patient. So this patient is gradually deteriorating. Fever is also persisting. By fifth day, fever should be decrescendo. Tachycardia, I said, low blood pressure, tachypnea, and SpO2 of 95%, though normally right now. So this patient appeared ill, dehydrated, conjunctival injection is there, which I said leptospirosis has conjunctival subfusion. Gingival bleeding is there, petechial rash over trunk and extremities, mild hepatomegaly and delayed capillary refill. So this delayed capillary refill is because of the patient going into shock, that means. So BP is also low, tachycardia is there, tachypnea is there. So all these things patient is maybe pre-shock to shock and patient has a febrile illness with hemorrhages. Now, important is, yes, it could be leptospirosis, the disease is progressing. The important thing is history of travel in this patient. This patient was is a recent traveler from, as Dr. Ravi said, from Uganda. So once you have that history of travel, that is what I am showing. If the history of travel is not asked, maybe we treat him as leptospira, maybe we treat him as malaria. But the problem is, if you get the history of travel, international travel, then you are on the sound, you are on the alert. So that is important for you to, each one of us to think about. And this is an important thing, especially when you have outbreaks. Outbreaks will not always come unannounced, announced. They will come and unannounced also at times. So next phase, brief one. You have fever, conjunctival suffusion. I said yes, conjunctival suffusion. So check for jaundice when you have conjunctival suffusion because I said icterus and petechial spots or conjunctival injection can be clue to leptospirosis also. And there is evidence of AKI. So this complex fever, jaundice, petechiae and AKI, this is suggestive of leptospirosis. So this is what I just said. So last case probably fever, body aches, and bilateral pleural effusion. This is very common. That is why I included it. So if you have fever, body aches, always ask for retroorbital pain also in these patients because it is quite commonly seen with dengue patients. And if you have bilateral pleural effusion, probably you are dealing with a capillary leak syndrome. So check for history, investigation. So next investigation, if you have capillary leaks or serous effusions, then you should think of hemoconcentration and get a hematocrit or packed cell volume along with the CBC. So likely severe dengue this patient. So I think the key take home messages are early recognition is critical and the history, consider epidemiologic clues which Dr. Himanshu will be dealing with. And it is important to distinguish from common diseases because they are much more common. But yes, simultaneously it is important not to neglect these less common or rare diseases because a good clinician or a good practitioner will need to have that international travel history or secondary contact history very, very importantly because that is the real crux when you actually want to pick up that disease and prevent an outbreak. So with that, I will close. Thank you so much. Any questions, I will be glad to answer.
Thank you, Dr. Anupam. We'll be having questions at the end of all
Okay, fine.
presentations. And I've welcomed all the participants to put their questions in the chat. So, as and when they pertain to you, maybe you can answer them in the chat. Thank you very much. We'll now move on to Dr. Himanshu Chauhan, who will give us the landscape of global landscape of uh, viral hemorrhagic fevers and the changing epidemiology. Dr. Himanshu?
Good evening. Hope I'm audible.
Yes, yes.
Yeah, thank you, Dr. Ravi sir, Dr. Anupam Prakash, Dr. Sonal, Dr. Nishan, my colleague, Dr. Madhumita, and others, and everyone who's connected. So, thank you very much for, first of all, amidst this gathering of clinicians and microbiologists who have a very deep knowledge of how this pathogen behaves, this particular one, Ebola, and the other viral hemorrhagic fevers that we are talking about. While I look at it from a public health point of view, my uh, presentation is also oriented, geared towards handling the public health aspects as to how we, Government of India, are dealing with the preparedness measures to keep our population safe, as we have successfully done. The Government of India has successfully done in the past as well, when there were much larger outbreaks of viral hemorrhagic fevers outside the country. So, with those few words, let me attempt to take you through the public health and the epidemiological aspects and the administrative measures which have been put into place to deal with this. If I may just share my slide deck, allow me a moment, please. Okay, I hope the slide deck is now
Yes,
visible,
yes.
the first slide of it.
It's visible.
Thank you for the confirmation, sir. Let me put it in a slideshow mode. All right. So it's been mentioned, and I'll focus my talk on Ebola disease, which is the current outbreak that we are dealing with. And essentially, most of it would be a recap. So I wouldn't go into the background or the virological aspects of Ebola virus disease. But then we know that this is one of the severe viral illnesses which caused by the family Filoviridae, and it affects human and other primates. It's also very well known to this gathering that 6 species, of which 4 are known to cause human disease, exist. The reservoir, while there's been mention, there are papers which have been published and bats have been implicated, but till date, conclusive evidence in terms of isolating the virus from the bats, it remains to be done. So reservoir, we are unclear as to how, where does it ultimately reside, and possible chains of transmission and then spill over to human beings are, are at this juncture, we only can hypothesize. Transmission, but we know that human to human spread occurs through direct contact, and we also very well know that blood, body fluid, secretions, or organs of infected persons, more importantly, possibly of diseased cases, are implicated in sustaining human to human transmission. The incubation period of 2 to 21 days covers the entire spectrum, including the longest incubation period that has been recorded. But on an average, it's 8 to 10 days. And thankfully, individuals are not infectious during the asymptomatic incubation period, making identification of these infectious cases easier than what the world dealt with during the COVID pandemic. Symptoms in the initial stage, as we all know, too, that the illness has a dry and a wet phase, with the dry phase mimicking most of the illnesses that we normally deal with, infectious disease specialists normally deal with: fever, headache, muscle and joint pain, weakness. And then in the wet phase, where diarrhea, vomiting, bleeding, those become prominent symptoms. And that's when the person becomes more infectious. While this particular strain that we are talking about, the current outbreak in Democratic Republic of Congo and other adjoining countries, there have been 10 identified now, 10 countries bordering Democratic Republic of Congo, which have been identified as high risk. The Bundibugyo virus, which has an approximately 50% case fatality rate, but we have also known strains like Zaire and South Sudan, which have 80% up to 80 to 90% mortality recorded. And for this particular strain, there's no specific treatment currently available, while we do have for Ebola Zaire strain monoclonal antibodies as well as a vaccine which is available. But for this particular, although the race is on, it's already on, probably very soon we might see a vaccine and some form of treatment as well. But as of now, there's none available. This is where the current outbreak is located. So just a quick recap. On 5th of May, when WHO was alerted of a high mortality outbreak in eastern part of Democratic Republic of Congo, northeastern part of Democratic Republic of Congo, bordering Uganda, that there was something going on, an unknown illness which is resulting in deaths. It took almost about 10 days, given the unique challenges that Democratic Republic of Congo faces, including civil strife and the rebels which control most of the northeastern part of Democratic Republic of Congo, making healthcare access to populations particularly challenging. So, about 10 days later, there was a confirmation of Bundibugyo virus in 8 of the 13 samples that were collected. Immediately realizing the gravity and the particular challenge that that location, that country has, WHO declared it as a public health emergency of international concern, the highest level of alert that WHO accords to any infectious disease, PHEIC. On 18th May, I think taking a cue from the WHO declaration, the Africa CDC, which is the agency which is responsible for all the African countries, the public health response in all the African countries, they also declared it as a public health emergency of continental security. So quick succession things started once WHO declared it as a PHEIC. It is not something new in Democratic Republic of Congo. Probably that's also the reason why the initial few cases, which may have started somewhere in the end of March, as now reports are coming in, and it would have just the transmission would have just been ongoing. But by the time it was detected, confirmed, it was already 1.5 months late, because there's already previous outbreaks which have been reported in that part of the world, including the first outbreak when DRC was Zaire, the first outbreak of Ebola in 1976, where 318 cases were reported, and then in the adjoining country of Sudan, where 282 cases were reported, and mortality rate touching 90%. So this is the 17th Ebola outbreak in Democratic Republic of Congo. But for this particular species or strain, Bundibugyo virus, this is the second in DRC and third globally. They also quickly acted upon and did a whole genome sequencing of the virus isolated from confirmed cases. And they found that this is not something which is already ongoing transmission or part of the earlier human to human transmissions. This appears to be a new spillover event, implying a fresh outbreak that has started as a zoonotic event spillover from some non human source. And it's genetically distinct from the earlier outbreaks. The current status, the numbers are fluctuating. Yesterday, CDC dashboard, WHO dashboard were quoting about 1,000 plus cases. A data reconciliation activity has been carried out by Democratic Republic of Congo Health Ministry, and they have now issued that 906 suspected cases, out of which 125 are confirmed, which also implies that there's a lack of diagnostic facilities in that area, which is understandable. And of the 233 deaths, 17 are confirmed in Ebola positive cases. In the adjoining country, Uganda, there's also 9 confirmed cases and 2 deaths. Some of them, it's debated that there's only 1 death, but official sources are quoting 2 deaths in Uganda. They're all confirmed cases. This has spread in the last few days that we are monitoring it from initial part, the Ituri province, which was northeastern, then it goes southern in the provinces of North and South Kivu, and increasingly more provinces are becoming affected. But as we all know, India has no case of Bundibugyo virus till date reported. So the actions quickly initiated by various countries once this was declared a public health emergency of international concern. Countries implemented enhanced travel screening, restrictions, and other public health measures to prevent importation of any case, including the US, Bahrain, Jordan, and there are some other countries also which have initiated similar measures. Government of India was already keeping a track of the situation as it was evolving. Our missions over there, they had already alerted us that there's an outbreak going on, and actual situation might not be known given the civil strife that is prevalent in those areas. So, but once WHO declared it as a public health emergency of international concern, immediately the National Center for Disease Control reviewed the scenario, assessed the risk for the country, realize that there's a need to develop SOPs, testing strategy, and other preparedness measures need to be geared up. And since then, almost on a daily basis, the reason why I could not join at 6 p.m. was the same as Dr. Nivedita could not join. We were both in the same VC wherein we were trying to organize, sensitize the designated isolation centers for a mock drill tomorrow. I think some of you are also part of those designated centers where the mock drill would be conducted. So almost on a daily basis, there's been coordination meetings going on. Different ministries are involved, and it's essentially a whole of government approach to be prepared to not allow any case to be imported. And if in case a minor there's a minor chance that it may so happen, then we are adequately prepared to deal with that too. So these SOPs, some of them would be useful to this group as well, especially the ones which pertain to lab related components. So these SOPs have been prepared. They are either already being uploaded on NCDC website or they are in the process. So you can have a look at that and refer to them for the sake of national uniformity that the guidelines are being followed in the same way across the country. The screening protocol at airports have been geared up, in-flight procedures, including in-flight announcements, self-declaration form. Now we know that a person can be asymptomatic for 21 days while he or she is incubating. So you can very well understand that a person who has traveled from Uganda, there's a direct flight from Uganda to India, by the way. So if there's a person on that flight, we will have to essentially monitor that person for the next 21 days if he or she stays in India for that duration. So it's a huge challenge, and we are doing that already. We have some 1,000 plus passengers who are under observation by our district surveillance units of IDSP. So this number will keep on growing because till the time there's an absolute travel ban, which WHO doesn't recommend, so these numbers would keep on adding. Airport procedures have been geared up in terms of all passengers being channeled through international travel help desks. There are thermal screening procedures which have been established. Passengers detected with fever will be separated by medical staff at help desks. And travel history to Ebola disease affected countries in the last 21 days with symptoms, they would be treated as suspect cases of Ebola. I'll come on to that classification just in a moment. So this will be bettered by an illustration that is on the next slide. So I'll be just referring to that particular slide. Self-declaration forms by all passengers has been made mandatory in case your known people who will be arriving on international flights, you can expect that they would be required to fill up self-declaration forms. Ports could also be realizing that there could be an option where a suspect case might come in through one of our seaports. So ports have also been sensitized about this possibility and measures have been put into place. Although the ships which directly sail from ports of Congo, they take usually more than a month to reach our ports. So by that time, the 21-day incubation period has already elapsed on ship itself. This is the risk categorization of incoming passengers at points of entry, which is our international airports essentially. So, passengers coming from Ebola affected countries are categorized as 1, 2, or 3, depending on if a person is asymptomatic and there's no history of contact that he or she reports, then there's just self monitoring, which has been recommended for 21 days. That can be done at home too, and daily follow-up by the state and district IDSP units is being undertaken in such cases. They are majority of the passengers who have arrived in the last few days. They belong to category 1. If there is a contact history present, that implies that he has been exposed, but there are no symptoms yet. So that passenger is categorized as category 2, and he or she is shifted to a designated quarantine facility. So that means there is restriction of movement for that particular person. He or she is expected to spend the next 21 days in a designated quarantine facility. And if there are symptoms, then obviously it becomes a suspect case, and the designated isolation centers would then come into play. The person would be isolated there, tested, and then accordingly decision would be taken. So all these SOPs that I was mentioning, arrival screening strategy, pre-arrival planning, quarantine management protocols, clinical management, referral protocols, lab testing protocols. NIV Pune is the lab where this testing is available. They have also included 10 more labs across the country. Some of you would already be a part of that network of these 10 labs where testing can be done for Ebola disease, and their training and preparedness measures have also been undertaken for contact tracing, isolation, disease management. Special type of PPE has been provided to these centers, lab protocols and IPC guidelines shared. States and UTs have also been sensitized about the measures that they need to take, so they have identified designated isolation centers for these. All IDSP state surveillance units have been sensitized to remain prepared and consider every symptomatic case with travel history to these countries as a suspect case and take necessary action. Preparedness of medical management measures, including assessing the logistics availability of PPE kits and other consumables, kits, reagents, sample collection and transport measures, and waste disposal as per the guidelines. They need to be followed. One of the important components of the whole of government approach to this preparedness measures is ensuring that there is real time countering of rumors and avoiding panic and misinformation at all costs. So we are sensitizing, we are reaffirming again and again in all our official communications by the government of India that there is no case of Ebola disease in the country. All the measures that are being taken are in abundance of precaution. This I've already talked about. The surveillance activities also I have mentioned that this entire system of lab and surveillance units, they have been aligned to the possibilities. This also I have mentioned 10 more labs have been included. There's also a plan to have few more labs in the BSL-3 network of ICMR and IV. The diagnostic algorithm shared by ICMR, I think you would have seen it by now, would have been widely circulated. So any suspect or probable case coming coming into the country would be isolated at a designated center. The samples would be collected as per the guidelines which have been issued. The primary screening would be done at NIV Pune now at 10 more centers. And if the result is positive, then it would be the first positive case of Ebola in the country. Accordingly, measures would be initiated by the government of India. If it is negative, it would depend on at what stage of illness the sample was collected. If it is within 72 hours, the current guidelines, which are yet to be issued, I think by today evening they would be issued. If a symptomatic person, his sample is collected within 72 hours, there's a need for collecting another 148 to 72 hours later. But if it has been collected after 72 hours of onset of symptoms, then a single test would suffice. Single negative test would suffice. That's the kind of special Tyvek suits that have been mentioned in today's training session also, that any suspect case, the clinical team and the lab team which would be handling this case would require to be wearing this kind of special PP. And it is been instructed, the states have been instructed that they need to have adequate numbers of these special suits available at the designated isolation centers. Different ministries are involved. I would not like to go into much details of these, but essentially because flights, you mean whenever there are flights, in flight announcements, procedures to be followed by international passengers, then Ministry of Civil Aviation is the nodal ministry. Filling up of declaration forms by the passengers is done by the airline crew. They facilitate this process. The Air Suvidha portal, as some of you would be aware during the COVID times, it's being considered whether it can be reactivated to make it more smooth flow of information possible. Infection prevention and control measures, not just by the clinical staff and the lab staff, but also by the airline people. The possibility of somebody symptomatic on the flight not being ruled out. Ministry of Home Affairs looking at the visa issuance processes, the Bureau of Immigration, the people where they would be reporting to the immigration counters, they've all been sensitized. External affairs, advisories have been issued through them. Some of the major summits that were planned, they have also been postponed or cancelled for the time being. And India has also offered support to Democratic Republic of Congo and Uganda. And there we have supplied our first tranche of medical supplies to them. DGCA has issued an order where there's mandatory self-declaration forms for passengers either coming from or transiting through Ebola-affected countries. There are standard in-flight and arrival protocols put in place and onboard PPE preparedness and crew training on Ebola response in case there is a symptomatic passenger on board. So, to summarize from a public health point of view and the government response to this current crisis, the risk of importation of Ebola disease into India remains low. We know that we have had the 2014 example wherein there were 11,325 deaths to be precise that were reported during that outbreak, which took almost 2 years to control it. But at that point, also, we were successful in preventing any importation. So our measures are only better as of date, and they are only much more advanced than what we had earlier. Preparedness measures have been put in place at various levels in abundant caution, as I said, including airlines, immigration, points of entry, our surveillance units in all the districts, and the designated facilities and lab networks as well. So I'll stop here, and I think if there are any questions in this regard, I'll be happy to take. Thank you very much.
Thank you, Dr. Himanshu, for a very detailed yet crisp way of presenting the current status and preparedness of India.
Thank you, sir.
I'm sure with our experience of the past, uh, 2014 to 16, where we have done a great job, we will be able to contain it this time in the event if we have a patient coming into the country. We'll take questions, as I said, towards the end. In the meantime, they'll be coming on the chat as well. Now, Dr. Nivedita Gupta, as Dr. Himanshu said, is unable to uh, join the meeting because she's quite busy with uh, the training and setting up preparations for tackling the. So, on her behalf, I will attempt to do her job. I must tell you that it's a very difficult job. She's been doing a great job, but I'll try and uh, try to tell you some of the slides she shared, and I'm very thankful to her for sharing the slides. Are the slides visible? Can somebody confirm?
Yes, sir.
Thank you. And Dr. Sonal has also helped in putting together this presentation very quickly. Uh, the case definition is important. As far as microbiologists are concerned, they should be very clear that they should know case definition thoroughly, as well as all the sample collection handling procedures. A suspect case is a case signs and symptoms compatible with VHF, which Dr. Anupam is very nicely elaborated in his presentation, and an epidemiological risk factor, which Dr. Himanshu said, within 20 to 21 days before onset of symptoms. Now, contact with a person with suspected confirmed viral hemorrhagic fever or any objects contaminated by their body fluids is something you have to keep in mind. Uh, Another important factor for healthcare professionals, including us, is if there has been a breach in the infection control practices, then that is also one of the things that you have to keep in mind. Differential diagnosis, Dr. Anupam has elaborated very well. I won't go into the details. In our context, it is dengue, uh, leptospirosis, and maybe Crimean Congo hemorrhagic. We have reported that in India. This slide kind of summarizes the diagnostic approach being taken currently across the world. Uh, there are initial screening tests that are available for the Bundi-Bujo virus, and it is a rapid point of care test that detects usually antigens to the virus or detects antibodies to Ebola proteins. This is only a screening test. The sample collection, I will go into details after this slide, and transport as well. Currently, as Dr. Himanshu mentioned, NIV is the designated laboratory for testing, and another 10 uh, VRDLs with BSL-3 facility are also being kept ready. NCDC Pune and NIV are the referral labs. The gold standard is RT-PCR testing. I'll give you details about it. And then, of course, that is the confirmatory test. You don't need anything beyond that, excepting that sequencing is a very important epidemiological tool for strain differentiation. So therefore, if a sample is positive, in the current context, it will automatically go for sequencing. Remember, the Bundibugyo strain has usually an incubation period of 6 to 7 days, and it can last up to 15 days and very rarely up to 3 weeks. Even if a person tests negative during this period, isolation and quarantine practices have to be continued, and repeat testing has to be done, as Dr. Himanshu said, if the sample is collected within the first 72 hours. The name Ebola is derived from the name of a river in northern Zaire, where the first case was detected in 1976. As you know, it belongs to the filamentous viruses family of Filoviridae and genus Ortho-Ebola virus. These are long, enveloped, non-segmented, negative stranded viruses, about 19 kb long genome. Because they are enveloped viruses, they're highly susceptible to bleach, heat, UV rays, as well as detergents. There are 6 different strains of species of Ebola virus that have been described. The first one discovered in Zaire, which is known as Zaire Ebola virus, the Sudan Ebola virus, the Reston Ebola virus, which was isolated and identified in Philippines, the Thai forest Ebola virus, which is from the islands, then Bundibugyo virus, which is in the Uganda and Congo, causing current outbreak now, and the Bombali Ebola virus. Now, as I said, the Reston virus is from Philippines. The Thai forest virus is from Ivory Coast. Bombali virus is from Sierra Leone, which is a Western African country. You'll all remember the 2014 one was an extensive outbreak which spread not only to various countries in Western Africa, but many other countries in the globe as well, including United States. Okay. We have had a patient who traveled to India from Liberia. I think this was in the year 2014. And this person showed, because of travel history, he was quarantined. And it was found that his semen sample was positive for a very long time. And almost up to 6 months, 4 months, sorry, He was kept, if you recall the press reports, he was kept in an isolation facility close to the Indira Gandhi International Airport. And finally, after he turned negative, he was discharged. Um, if you look at the kinetics of the responses in Ebola virus, uh, what you normally see is viremia that lasts anywhere between the second or the first day after infection. It reaches a peak around the seventh day, and viremia can last up to 21 days and sometimes even beyond. The peak viremia is seen between 5 to 10 days. IgM starts appearing at the end of first week and IgG at the end of 10 days. Now, RT-PCR is typically positive from day 3 onwards, as long as viremia is present, so definitely up to day 10 or day 15. ELISAs that are available for IgM are invariably positive 10 days post infection, whereas IgG is slightly later. If you look at the Gantt chart or the chart related to timelines as well as the various body fluids that are involved, as I said, viremia usually is up to 1 to 2 weeks, but can go on to third week. So also shedding a virus in urine and tears uh, is has been recorded up to 3 weeks. The saliva sheds virus. You can detect in saliva up to 10 days. Uh, it is very interesting that in the sexual fluids such as semen and vagina, that the detection is usually beyond the second week or third week, and it can go on up to 3 to 4 months. It's uh, Feces also, you can see virus being shed up to 4 weeks, and milk, which is a secretion, transiently can show virus between the second and the third week. Now, these are documented facts. Uh, as far as the Bundibugyo virus is concerned, the current outbreak that is occurring in Congo and Uganda, it's interesting that the genomic sequences are clustering separately away from the earlier genomes. And this is the data of at least 3 genomes that has been released as late as 18th May 2026. Now, specimen collection and biosafety are the pillars for any microbiologist and in public health. Preferred specimens are whole blood, serum, plasma. Other fluids include saliva, urine, semen, and CSF. BSL, it's a BSL-4 pathogen. I'm sure you know that. Culturing the virus has to be done only in BSL-4 laboratory. We have one in NIV Pune, and we have an animal BSL-4 laboratory in Bhopal. Uh, Remember, repeat testing is needed if initial PCR is negative. Now, blood 4 to 5 ml to be collected in both EDTA vacutainer as well as the yellow capped serum tube. Urine samples 3 to 5 ml in a plain tube. Stool samples or rectal swabs, oropharyngeal and nasopharyngeal swabs are to be collected in VTM. Generally, postpartum samples are not recommended, but if it is mandatory, tissue samples such as liver, spleen, bone marrow, and kidney, lung, brain. Now, there are several prerequisites for specimen collection because this is what, if at all, any of us microbiologists will be called, especially the 10 VRDLs that are going to do it. Identify a patient isolation room, identify a room for donning and doffing of PPE, prepare specimen collection kit, and also keep everything for packaging and transporting ready, have a spill management kit ready, identify always an observer who will check the list as well as be around to see that there are no lapses in the infection control practices. And remember to fill all the details in the clinical request form. It's advisable that as a team is involved And on the PPE, the teams have to be identified with a label as doctor, nurse, or lab technician, so that within PPE, most often you will not be able to talk, so you'll know who is in the team and what they're doing. Now, for the sample collection material, you need, as I said, EDTA tube and yellow colored serum tube, plain tubes for urine sample, sterile polypropylene swabs, viral transport medium, leak-proof containers, parafilm, marker labels, marker pen, and surface disinfectant material. Now, for hand hygiene, use alcohol-based hand rub as recommended, or wash under running water with soap and disposable. Remember, all this is after double gloving. Several pairs of disposable gloves are required. One pair for sample collection, discard that, use another one, double gloving, so that if there is any small puncture or anything, you are definitely protected, and 0.5% sodium hypochlorite to be kept. Now, what is recommended is a Tyvek suit. A Tyvek suit is Tyvek actually is a proprietary name of a company that first developed it. I think it's DuPont. But basically, a Tyvek suit is the one that has a hood included in the PPE suit. It's fully sleeved with elastic bands at the ankles and the wrists. Now, you should use an N95 mask, an eye shield, goggles, and a double pair of gloves, as I said. You should have all the disinfectant and waste management materials handy, such as sharps container, leak-proof, puncture-resistant, and as well as requisite disinfectants. Now, hand hygiene is very important. As I said earlier, that alcohol-based or running tap water. And this Dr. Himanshu has already told you the kind of the precautions for sample collection as well as for handling the specimen BSL-3 laboratory. It is recommended that the lab uses the BSL, the person working in the BSL-3 lab handling a specimen should have a respirator as compared to the people who are collecting specimens. And proper disposal of every material, especially any spillage, ensuring that you wipe the outsides of the BTM tube with tissue paper, which is discarded appropriately. I think COVID has taught us the triple layer packaging. The first one being watertight primary plastic receptacle that is resistant to breaking, unlike glass. Then watertight secondary packaging, and then rigid outer packaging. And of course, putting the label in the secondary level packaging, and then sending the container upright. This is the diagnostic algorithm which Dr. Himanshu talked about. As I said, if the sample is within 72 hours, you need to repeat a sample if it is negative, so that you ensure that you don't miss out. Remember, if a sample is negative for Ebola, you still need the in the network at a national level to screen for other possible hemorrhagic virus such as Marburg and CCHF, which are relevant to India. And also probably locally later on, it will go for screening for dengue and leptospira and so on. RT-PCR is the standard diagnostic test and the gold standard test. Genes generally that are targeted for amplification are nucleoprotein, glycoprotein, and viral polymerase. A positive result confirms diagnosis. This is the diagrammatic representation of Ebola virus. The NP, the GP, and the L regions of the virus are the ones that are amplified. A number of commercial RT-PCR tests are available. For example, the one mostly used is Altona, highly sensitive. Uh, the Altona is preferred over the others because it detects the Zaire, the Pundabujo, and Sudan, and the Ivory Coast, And you can also differentiate Marburg from Ebola. It has a very high sensitivity of 1.8 copies per microliter and 100% specificity for the Zaire virus. There are many others. Gene Export has one that is the Cepheid Gene Export has and you also have the Filmarase as well as the Idilla Ebola virus test. But generally, the most widely used test is the Altona one. And the virus, this is about the Altona kit, Real Star Filovirus screen. They have two versions. One is a screening test to tell whether Ebola and Marburg is available. It's a multiplex PCR, and based on the dice, you can decide whether it is Ebola or Marburg, or it's negative for both, depending on the FAM and Joe positive is Ebola, Sci-Fi and Joe positive is Marburg. And you also have the species differentiation kit, which is a 4-tube assay, where the first tube has one type of virus, and the second tube and third tube and fourth tube, so the third and the fourth have two different strains of virus amplification primers, and based on the signals you can differentiate whether it is Sudan virus or the Bundibugyo virus. Rapid diagnostic tests have been developed and evaluated during the 14 outbreak. There are many of them that have been developed, and they're all named here. The Ora Quick Ebola, the Zaire antigen, the Quick Navy Ebola. They mainly detect VP40 antigen, nucleoprotein, and glycoprotein. The advantages and results are available within minutes, but sensitivity is not as good as the RT-PCR, but it's good as a screening test. And these are all the various the rapid diagnostic tests available and the kind of targets that they detect. The other serological methods are ELISA um, and immunofluorescence assay, both of which are directed at detecting the immune response. As you know, immune response detection usually is available after 10 days after onset of symptoms. And virus isolation is to be attempted only in BSL-4 labs, and the virus grows very well on Vero E6 cell cultures. Electron microscopy is more of an academic exercise, and but the pictures are really beautiful for the virus to be seen. Genomics surveillance and technology is very important. As I said, during the 2014 outbreak, genomic sequencing was extensively used, a lot modified and made, field compatible. Uh, and today, genomic sequencing platforms as well as reagents are available for at-site verification in temporary BSL-3 labs that are established close to sites of outbreak. And this is a Nature paper that was published where portable sequencing using nanopore technology was discussed and evaluated. It is used for transmission tracking as well as collecting data for developing monoclonals, which is one of the treatment modalities as well as vaccine development. The upcoming technologies, there are two that have been mentioned: surface enhanced Raman scattering. Now this detects antigens as well as antibodies to Ebola viruses, and the Tachman array card, which is the developed by CDC, which is a card in which you can detect more than 18 agents, including viruses like all the hemorrhagic viruses, in addition, chikungunya and Hanta virus as well, hepatitis B, Marburg, Nipah, Onyong, Rift Valley, and so on, as well as 8 bacteria like Bartonella, Coxiella, Leptospira, and so on, and some parasites. Now, this is, as I said, developed by CDC, and it is employed by CDC in outbreaks. So, thank you, and I'll conclude my presentation. If there are any questions, we'll take it at the end of the session. Thank you. May I now request Dr. Madhumita to tell us about infection control, prevention, biosafety, and outbreak preparedness. Dr. Madhumita is from NCDC. Over to you, Dr. Madhumita.
Thank you, sir. Good evening. And thank you, Sonal ma'am, for giving me this opportunity to speak in this gathering. And initially, I thought it will be a challenging for me to cover such a big topic. I just share my screen. And I'm thankful that I am the last speaker. So most of the part has been already been discussed by Dr. Himanshu and Dr. Ravi sir. Is my screen visible?
Yes, Madhumita.
So since I was given a huge topic, and individual topics are such a big ones, and it's very difficult to summarize in the given time of 20 minutes. So I really thank Dr. Himanshu Chauhan, who's an IDSP nodal officer, who has already taken most of the part which I was supposed to cover, and Dr. Ravi sir, who has already taken most of the laboratory practices in detail. So I quickly go through what are the assignments, what are the given to me. So the learning objectives of this particular presentation was the infection control precautions in the hospital and isolation practices in case of the current Ebola infections, then the type of PPE, biomedical waste management, then the laboratory biosafety and exposure management, preparedness, planning, and outbreak response, lesson learned from recent outbreaks. I would like to deal each topic which was given to me in a concise and a brief manner. And quickly, I'll go through that. So when we talk about the infection prevention and control, this is something which is already there. I mean, there is no other additional protocols which we have to follow. So this infection prevention control measures which are already in place, they have to be they have to be monitored. They have to be the IPC team of the hospital needs, so the healthcare facility needs to gear up, and they need to go through their protocols, whether they are in place or not. So I'm not going into that detail. The government of India has already in 2020, before the COVID has struck, they have launched the national guideline for infection prevention and control, and each session has been nicely described in this topic wise. It is described in the PPT presentation is also there. So in all the general conditions, whether it is an Ebola or whether it is an infective disease, the practices in the hospital or in the healthcare facilities needs to be same as in particular to infection prevention and control. There should not be any breach, there should not be any compromise with that. So one can go through these sessions directly, and then if we talk about the very specific ones in this country, in this scenario, it is the IPC ring approach. So when we talk about these highly infectious agent, so this is the IPC ring approach, is a strategy in which rapid, intensive, and IPC measures is delivered to the healthcare facilities. So there is the areas where the Ebola transmission to is there, and there too. This is just to break the chain of transmission. So IPC task force is to be established, and it has to be established. It has to be worked out by the Ministry of Health, and this task force needs to activate the IPC ring within the defined parameters. There is a geographical or the hospital care setup in within the 24 hours of the case, and 24 hours within the 24 hours of this case. Then healthcare facility intervention, once it is there, then there are a lot of interventions are required. So first and foremost is the decontamination by sorry, it's 5% hypochlorite, and surfaces and equipment so has to be decontaminated. Provide IPC kits, briefing of the healthcare workers, rapid IPC assessments to do the gap analysis, and the so that there can be any improvement if it is required can be done. Then regular supportive supervisions and periodic reevaluations and trainings are the core of it. Sorry. So then is the screening and triaging. So first, then in the screening, the individual is evaluated to see whether that person meets the standard case definition. As Dr. Himanshu and Dr. Ravi said, the first is the case has been defined. So the screening is done, and this is done in no touch approach. At least 1 meter distance should be there, and this is maybe done by the thermal scanner or by a set of questionnaires depending on the sign and symptoms. Then triaging is where these patients are sorted into the categories based on the need for time sensitive treatment, whether they need an immediate intervention or they can wait safely for a few more days, and the more immediate ones needs to be quickly attended. So once the patient is suspected, so first and foremost is immediate place of the placing the patient in the isolation area. So in these conditions, it is referred in a single occupancy patient's room, and which have the dedicated of only for a single patient. If cohorting is required due to any space issues, then suspected and confirmed cases should not be kept together, and the suspected case can be kept cohorted, and the confirmed case can be cohorted separately, and within the patients there should be at least 1 meter of distance. So whether it's a suspected case room or the confirmed case, but the few important parameters are the restrict the access of non-essential staff. So only the dedicated only the staff who is assigned a particular task is supposed to enter into that particular area. The clear signages should be there, which will clearly keep the other patients or the other staff entering into that area. So equipments which are kept in the isolated rooms shall not be used in the other areas. It is mainly seen when they are portable X-rays or portable any other medical devices which are being taken in the isolation room and out of to other areas. So this should be absolutely strictly avoided and should not be done. Then dedicated patient toilets so should be there, and which should be ideally should be attached with the these patient rooms, so that the patients are not coming out for their daily activities out of that isolated area. Donning and doffing area should be there for the patient care healthcare workers who is going to give the care, and hand hygiene stations are foremost important. So when we talk about such conditions, it is already a psychological pressure is there. The patient is undergoing a psychological stress, a trauma. So interaction with the family members in a safe manner is again a very important this thing. And yes, it can be done in the isolation cubes, or maybe better if it can be done by a telephonic communication. So this is the part when we talk about the isolation. Then personal protective equipment. So we all know about the PPE, but here the what I want to talk about the individual PPE, like what the scrubs, and that's the trousers and the tops. So when we are dealing with the patients of Ebola type of diseases, it is not that we are wearing our Tyvek suit or our gown, I mean the coverall over our daily household daily dresses what we are wearing from our home. We need to change from scrubs in scrubs and tops, and then we have to change our Tyvek suit. So our internal clothes needs to be taken off, and we need to wear our scrubs, and on that we need to put up our disposable coveralls. So these scrubs are not supposed to be taken to the homes back and for washing, and they should be autoclaved and they should be laundered and in the facility itself. So footwear, we all know about the footwear, but important is that they should be closed toe coverings from the dorsum and the ankle, and they should be fluid resistant. Preferred is a rubber boot, and if it is available, to the knee length. Goggles, it good seals with the skin and face without pressure, and should accommodate, be able to accommodate the prescription glasses. So there then besides goggles, there is a face shield, which is a clear plastic, good visibility, cover side and length of the face. This is also there when we use a paper. So otherwise also the face shield is important when we are dealing with not in the BSL lab, but otherwise also we are in the patient care areas. So medical or surgical mask, good breathability, non-collapsible and nice. Since we know that this is not aerosol transmitting infection, so in that condition, we don't need a N95 mask. Gloves should be nitrile and proper size, and they should not be loose or very tight, so that can be easily the activities can be easily carried out by the healthcare professionals. So what are the recommended PPE when we are dealing with such kind of patients? So I think this is okay. So during screening, no PP is required, and if we are having a no touch technique and there is a barrier between the screener, the healthcare worker, and the patient. If the screening is less than 1 meter, then definitely the scrub suit has to be worn. And on top of it, there's a fluid resistant gown or the overalls, shoes, one pair gloves, medical mask with eye protection, face shields or goggles. And even we are if that's the same in if we are doing the triaging, so when it is understood that we are close to the patient while we are assessing the patient, the clinical assessment is done. So again, it is a scrub. On the top of it has to be worn a fluid resistant coverall, shoes, one pair of gloves, and medical mask with eye protection. But during patient care, it is important that we have to wear the two pair of gloves, and that is nitrile gloves. So this is the difference between the recommended PPE uh, when we talk about the patient care. So there are many lot of things which could have been discussed in this IPC measures, but I am focusing on the important ones. So hand hygiene. So hand hygiene, we have to remember that wearing gloves is not a substitution. So hand hygiene is most important and has to be done by soap and running water. As previous speakers have said, they are envelope viruses, and envelope easily gets destroyed by the soap action of alkalis and soaps and the alcohols. So use of alcohol based hand rub is again very important. We should always remember the 5 movements of hand hygiene. This is the basis of our IPC measures. So the 5 movements of hand hygiene has to be followed, and the steps of hand washing has to be followed. So most important is ensure supply of resources. So this is something which IPC is always said, that it is not only a part of a healthcare worker, like the person who is giving the care, but it is the administrative support also, where it to ensure that the supply of resources are available, so that these protocols can be followed. Placed in critical locations is again very important. Besides the bed, before leaving the room or the wards, it is very important that the alcohol hand rub and the sinks with the soap and running water is placed properly with, and of course the running water, the availability of running water and the soap is also very important. Then when we talk about the cleaning and disinfection in this conditions, so cleaning of the environmental cleaning, like is and disinfection is a safe handling of potentially contaminated material, has to be done very diligently. So surface disinfections has to be done by the hypochlorite solution of 0.5%, and has to be by 10. So it is seen that if it is sprayed, it is better to wipe the areas, the critical areas like door handles, then bed rails, the areas where the patient is probably has been touching or is in contact with. So if there is a visible spill of blood or body fluid, then the spillage has to be taken care by 10% sodium hypochlorite. Then mopping of floors is advised twice, and if visibly soiled, then definitely that particular time also. So first is disinfectant, and then cleaning is the protocol while we are mopping the floors. So we will use the disinfectant first, and then we will do the cleaning. So then when there is a linen, we the linens are need to be autoclaved and then laundered. It doesn't go for the washing first. So it has to be packed in bags, and the person who is taking care of the linens, changing the beds, needs to again wear the recommended PPE of the patient care type, and then they need to handle the linens. If the linens have a soiled with heavy fluids, these needs to be discarded and incinerated, and this has to be ensured. So then training is most important in all these factors to achieve the chlorine, the training of the housekeeping staff who is doing the cleaning, so that's to achieve the chlorine concentration, to conduct disinfection and cleaning process. So training and supervising of the activity is very important. Coming to the waste management, all waste generated from the care of the patients with suspected or confirmed has to be decontamination process, should be treated as infectious waste. So waste segregated at the point of generation, which we all know, and should not be stored more than 24 hours. So appropriate PP recommended when handling infectious waste. Again, it is not only the gloves or the boots are weird, but proper PPE has to be worn by the person who is dealing with the handling infectious waste. Then ensure the waste disposed in a safer manner, that we do a pre-treatment of those waste. Now, safe management of the disease. So this, as Dr. Himanshu said, these protocols probably will come up more guideline, but these guidelines are been taken by the right now, since our country doesn't have the disease yet in our geography, in our land. So these guidelines, these are been taken up from the WHO guidelines. So what this is that the individuals handling the disease need to wear the complete PPE, same as the one for the caregiver. Then undressing or redressing the disease are strictly prohibited as per the culture permits. So cultural beliefs are there. So no need to dress or redress the disease is, it's recommended, it's not recommended. And then the diseased body is placed in the body bag of impermeable quality, and then it has been safely given for the incineration, disposal, the burial, or the incineration. So disinfection of the body is likely of no additional benefit if IPC measures are appropriately applied. So, and it is not to be attempted also. That is why it is said that when in our COVID days also, we have seen that the patients were not handed over to their relatives, because that is the time in Ebola cases when the viral load is the highest, and the chances of infection are maximum, transmission are maximum. Then if there is an exposure due to some practices, due to some activity in the hospital or in the healthcare facility, so that for that the SOP should strictly be there, which should guide the type of exposure. Then immediately the person, this is the common ones, the common steps what we follow in all kind of exposures are that immediately we have to stop what we the current task which was doing, and immediately wash with soap and running water. Leave the patient care area, move to a safer environment, remove the PP. Then inform the exposure event to the designated person. So these all are to be a part of the SOP, whom to be informed, what is the cell number, what is the mobile number, where is the designated person sitting. So these all should be covered by the SOP, and these SOP should already be in place. Now, maybe the patient is dealing with the Ebola, but there could be any other infective agents of potential exposures. So HIV, HBV, and HCV like of viruses should also be taken care of. Then because the incubation period is 21 days, so the person will not be assigned any further task of doing any particular activity in that in the area, in the patient care area, but has to be excluded and should be observed for 21 days for any development of any sign and symptoms, since the incubation period is 21 days. So that I have not gone into much detail. So that is the IPC main areas which should be dealt in case of Ebola. Now, coming to the biosafety laboratory practices, so there are two, before we move on, there are two things which we should understand very clearly. What is a biosafety? So when we talk about biosafety, it is a safety procedures which will keep ourselves, the person who is dealing with the pathogen, and not getting exposed. So it isn't the contaminant, the contaminant principles and technologies and practices that are implemented to prevent unintentional exposures, right? So if I'm working in a lab, I should not be exposed, so that should be my working protocols. Now, what is biosecurity? It is securing the agent from bad elements, so that there is no leak, no outside movement of these agents, high risk agents, outside the lab, outside of the containment area. So when we talk about this biosafety, it is to keep bad bugs from the people, but biosecurity is keeping the bad people from the bugs. So if we combine both, it becomes biorisk. So why is biosafety important? It is mainly when we talk about the laboratory practices. So laboratories should recognize hazards of processing infectious agents, and there should be guidelines to develop the protect the workers in the microbiological and the medical labs. And it is not only by the procedures what a person is doing the activity, it is also done by the engineering controls, the management policies, and the standard work practices. Now, principles of biosafety, it is safely handling the biohazardous material without infecting oneself. So it is achieved by risk group identification and risk assessment of the facility, practices and procedures, what we are going to do in the lab, control of materials, the equipments, environmental and engineering control, restrict the access. If somebody thinks biosafety is only about the practices and procedure, it is not only that. What we are going as a microbiologist, we are doing in the lab, but complete facility is to be monitored. That is the principle of biosafety. Laboratory safety is every person's responsibility. So when I say every personal, it is not only the person who is working inside the lab, but it is the responsibility of the person who is monitoring my engineering controls, also who is monitoring my HVAC system, who is monitoring my air handling unit, who is monitoring my HEPA filters. So that is also important. They are also important part of this biosafety protocols. So this is quickly, I'll go through this because we all know about the biological risk group identification. We do it on the basis of the type of agents. Now here we are mainly dealing with the group 4 agent when we talk about Ebola, and in this condition, in this particular case, when we are talking about Bundi Bugio virus, where we are vaccines is not known, treatment is not known, and actually we don't know how the disease is presenting. And a biological risk group assessment, when we are doing it, is very important. When we are talking the group assessment, the grouping is done. One factor in this grouping is endemicity. As Dr. Himanshu said, that this many of these cases have been reported in the African subcontinent, but we are more because they are been dealing it with since time. So they are maybe they have developed some kind of resistance, or the antibodies, whatever, but we are more into the hazard, more into the risk. So patient risk group identification, high risk patients using the surveillance data and clinical markers. So immunocompromised status, if the patient has undergone any transplant surgery, or the undergone any cancer therapy, or having any invasive devices, or any geographical exposure, having any travel history. So these are the patients who are on high risk. Then procedure or environmental risk factor assessment, as I said, that infection control risk assessment, it is a facility design. It is not only the lab inside, whether I'm working in a BSL-3 lab, biosafety cabinet, I'm having my equipments in proper, but my complete facility design is equally important. How my access is there, how my entry is there, whether my all systems are working or not. So airflow is in a proper direction or not, whether it is in a negative pressure or not. So these are all procedures and environmental risk assessment has to be done. So then the applied controls, as we can see that if we see the hierarchy of the control, PPE is the one which is at the least part, where we can see that more important is the administrative and the environmental controls, where the part are more has to be more taken more monitored. So when we talk about the biosafety level, systematic approach is disrupting the chain of infections. So this is the biosafety level. If there is an infectious agent, and we have to stop the infectious agent to transmitting to the susceptible host. So there are few parameters, few protocols which we need to take care of. That is a personal protective equipment, medical surveillances, and the engineering control and of the equipment and good work practices. So what are the primary containments? Is the primary barriers, is the physical barriers of the first line defense. That is the PPE and the biosafety cabinets. That is a class 1, class 2, or class 3. Many of us have worked in these biosafety cabinets. Then secondary barrier is a structural aspect that make working environment safe. That includes the facility design, the operational practices, the equipments which I'm working, the spatial containment areas, whether my sinks are located, spatial air ventilation system is working. So these are all secondary barrier part. So when we are working on this, and this is just a point which again very basic but very important to highlight, that the standard microbiological practices should be in place, whether we are dealing with whatsoever type of pathogen. That universal precautions need to be in place. Then good laboratory practices, as a microbiologist we need to follow it when we are there in our lab, whether we are dealing with Ebola or whether we are dealing with any other laboratory pathogen, any pathogen of any risk group. But we have to follow the good laboratory practices. So when we talk about the biosafety level, so I'm just going through it fast, because this will build the situation of biosafety level 4. So when we talk about the level of biocontainment, this is BSL1, where it's a basic laboratory where we can use open benches or cabinet or sink for hand washing. BSL2, where it is can be used for the diagnostic services, where the standard microbiological practices are there, protective clothing, biohazard signs, and this requires biosafety cabinets, whether 1 or 2. Then in the BSL2, there's a directional airflow, and 70% of this is recirculated. Control access should be there to the lab. So every lab cannot perform test of every organism, as we have just gone through last 2 PPTs. So BSL-3 is a serious disease transmitted by mainly by aerosols, that is MDR, TB, or hantavirus. And then in this condition, the spatial containment labs are there. Only the trained personnel in the BSL-3 lab can work and should be allowed. It has to be controlled access. So controlled access means it is not that the either by the biometric system or by a card system. It is the control should be given to the personnel who is only trained to work in the BSL 3. And mind it, when I'm talking about BSL 3 trained worker, means it is not only the lab, I mean not the scientist, but the housekeeping staff also needs to be trained, because they are eventually going entering and they are dealing with the biomedical waste and they are cleaning the disinfecting the area. So BSc biosafety cabinets for potential aerosols with HEPA and directional airflow is there, and with negative airflow by AHUs, dedicated AHUs, and that AHU is the air handling unit, and it will have 100% exhaust. As we have seen in the BSL 2, there are 70% recirculation, 70% air can be circulated back after HEPA in the lab, whereas in BSL 3, 100% needs to be exhausted. And there is a double door airlock entry. While coming out, we need to have shower means a proper shower, protocol for decontamination of labs and clothing. So here we are wearing our scrub suits, on the top of it we are wearing our coveralls. So everything remains in the lab itself, and only we as such come out, take our shower, and we come out with our clothing which are kept outside. So this is typically I mean it's a very a processed flow of the working in the lab. So then this is a BSL 4, where the lethal disease can be dealt with, and it's a maximum containment lab where practices of BSL 3 plus is there, with positive pressure ventilated suit. So here I would like to mention or highlight that in India, there were two BSL 4 labs, which is NISHA, that is National High Security Animal Disease, that is Bhopal, and NIV Pune. So recently, I have been fortunate to visit Nishad, and I got some training on BSL 3 protocols also. So therein which they have said, because if you have gone through the recent guidelines in 2024 on BSL establishment of BSL 3 BSL 4, there's some certification and some clear categorical requirements are there to name it as a to label it as a BSL 4. So Nishad has labeled it back to BSL 3. They are not saying them, they are not claiming them to be a BSL 4 anymore. So right now there are only one BSL 4 in the country, that is NIV Pune. Now, there could be a confusion that now if there is an Ebola case comes, who is going to do the testing? So let me clarify. When as Dr. Himanshu has also highlighted this, that currently NIV Pune will do, but then 10 further subsequent labs are coming up. So if that is the 10, these are 10 BSL 3 labs. So if we are keeping our BSL 3 protocols in place, in BSL 4 protocols in place with a wearing a positive pressure ventilated suit. This is a paper where there's a positive pressure ventilated suit is there, and other BSL 4 protocols are maintained. We can deal the pathogen, we can deal the Ebola virus in the BSL 3 lab till the inactivation process is done. Once the inactivation of the virus is there, we can carry the rest of the activity of identification in any BSL 2 lab as well. So the BSL 3 lab is required for the dealing of this pathogen. Also, if we can have the all the practices of BSL 4 with positive pressure ventilated suit using in the BSL 3 itself. BSL 4 lab is required definitely for culture. If we are going to do BSL 4, the Ebola culture, or we are going to do any research kind of thing on the on the Ebola virus or the Marburg virus or the lethal, so we have to we have to do these in BSL 4. So I think this is I have clarified this. So BSL 3 is required mainly. We can work with the Ebola virus till the
Dr.
inactivation.
Madhumita, sorry, can you wind up, please? We need
Yeah,
time
please.
for questions.
Mm. So biosafety level laboratories for the microbes, this I've already done. So Okay, so BSL 1, this is again will build up what the practices of BSL 4. This is a use of personal protective equipment, frequent hand washing,
I think
dose.
most microbiologists are
Yeah,
available.
I think this is there, but
Yeah.
only what I want to say is this: when we come of the BSL 4, so all the practices what we do are the BSL 1, BSL 2, BSL 3 that has to be followed for the BSL 4. So now when I said explain that BSL 3 can be used, so use the BSL 4, that is the positive pressure personal suit, and do the protocols of BSL 4 in the BSL 3 to carry out this. So this is something which is air handling unit. So this is dedicated for BSL 3, BSL 4. So this is a sync which is important, and where I want to show that these are the typical ones where this is a hands free and can be operated from foot and has a U bend so that there is no backflow. So signs and labels are there. This is again BSL 3 lab designs are important, where the 12 at least 12 air changes per hour is important, and to have a proper air circulation and negative airflow into the lab. So this is triple layer packaging. This has already been explained. So next was my preparedness. Actually, Dr. Himanshu, I'm so sorry. Dr. Sonal has given me such a huge topic. I'm trying to squeeze it out. So preparedness, planning, and outbreak response was also part of it, and lessons learned from the previous health emergencies. So here I'll just quickly go through, and I'll try to take the lessons learned from the previous health emergencies first before I talk about the preparedness, planning, and outbreak response, which you have already talked about. So here, when we talk about the lessons learned, it was the preparedness and the work. So it is the capacity of the labs, the systems should be there so that it should be prepared in place. And health is everyone's business, means health is, whether it is only the person who is getting infected is not the concern of that person, but whereas the political leadership to the community engagement by everybody, and the sectoral it's the cross sectoral issues, when the health is has to be taken care by everybody. Then response must be agile and adaptive. So as pandemic progresses, it has to monitor new developments, consider contingencies, adapt evolving circumstances. No one is safe until everyone is safe. That is the policy what we have learned in COVID-19 pandemic. So this is the lesson learned. So out of the lesson learned, that the strengthening, I'll just go quickly. The strengthening approach, operational capacities can prepare public health and other sectors. That is the, now we have the coming of the One Health approach. It is not only the human health which is taken separately, and the other sectors can be left over because it's a human disease, only thinking about the humans are getting affected. So stronger surveillance and laboratory capacity. This already many of these have been spoken by Dr. Himanshu. So robust surge and capacity for critical components, where we have seen that the demand of the oxygen and so many issues were so critical when we were dealing with the healthcare emergencies. So this is again an important step: development and production of medical countermeasures, supply chains, maintaining the supply chains. Close partnership between the government and non-governmental entities also is a very important factor, when where we can have a platform where the health can be dealt with. So long-term sustainable investment in routine public health and primary care services is again very important. So resources should keep flowing, and any point if there is a short of resources, then definitely the health will get compromised, the health conditions will be compromised. Strong social net policies, safety net policies are important, and stronger mechanism for internal cooperation and coordination. One part you have seen that India is yes, last time also they have helped other countries, and this time also we are extending our hands to other affected country. So preparedness, planning, and outbreak response. Dr. Himanshu has very nicely explained it. So I'm not going to go into that detail. So this is just one picture
Madam, I
where
think you have to wind up
yeah,
because we have totally run out
yeah,
of
yeah.
time. Most of it
I
has been
think
covered. Thank you
yes,
very
yes,
much for
yes, yes,
your
yes.
detailed.
Madhumita, the meeting will end at 8 o'clock.
Yeah,
Yeah,
the
ma'am. Actually, मैंने आपको कहा था this is a bigger topic, but only this slide. Let me go through this particular slide. because this is in a general which we are talking about when we talk about India's preparedness and planning. So after COVID, actually, there was a pandemic preparedness program which was going on, where the surveillance readiness and biosecurity testing, workforce development, these all are being taken care of. The National One Health Mission, under which the laboratory network of BSL-3 and 1 BSL-4, that is at NIV Pune, is being established. So this is something which is important for a upcoming microbiologist should be knowing. So
Thank
I
you.
think
Thank
we
you very much.
can, yeah, we can wind it out.
Thank you. We are barely left with four minutes for any questions. I think people have been continuously interacting on the chat. So there is any pressing questions from the participants, you're most welcome.
Sir, I think most of the technical questions have been answered.
Yeah.
So, but I don't think there is any other relevant question.
Okay.
Like,
So then we can conclude, Sonal.
Hanji sir, I think so.
Thank you. Thanks to all the speakers for their putting a lot of effort and making this symposium very informative. Uh, the single message is that viral hemorrhagic fevers are no longer distant or exotic. With international travel, changing ecology, and healthcare system preparedness and diagnostic preparedness, I think it's now a reality. It's only a question of how we are going to deal with it if we have a patient. And the role of microbiologists has been very clearly alluded to by every speaker, uh, confirming the diagnosis. And as of now in this country, NIV and another additional 10 labs will be doing the diagnostic testing for confirmation. But all of us have to be well aware about sample collection, biosafety, interpretation of results, and uh, sequencing as well, so that we are able to answer questions that come from the public. Thank you very much, and thanks, Dr. Sonal, for giving me this opportunity to moderate the session. Thank you.
Thank you,
Thank you,
sir.
ma'am.
Thanks.